So I think Ashad has nicely set the scene that, especially in the NHS, we've got a huge burden of care, and we are trying to reduce that and hoping to have longer duration therapy, which hasn't been fully answered in terms of the question by the FDA trial designs. But what we'd love is better outcomes for our patients, and I'm not sure if we necessarily have got better outcomes for our patients since we started having VEGF-A inhibitors in 2007, 2008. So I'm going to kind of take a step back and recount the journey of how we've evolved to our current treatments and what the gaps in, and maybe what better treatments we should design. These are my disclosures. And I'm going to describe the impact of neovascular AMD on quality of life, the evolution of therapies over the last 20 years, and should we be targeting something beyond VEGF-A alone? As retina specialists, we're all aware that loss of vision impacts on our patients. And in a new digital world, my mother now has to do online banking, and this is even more critical to maintaining independence, be able to look at your smartphone and your iPad. And good visual acuity is even more critical, I could argue, than before for all these tasks shown here. And from a number of different studies, 1 in 4 adults who have meaningful visual loss have secondary depression or anxiety and struggle to maintain independence. What was a surprise to me is delving a bit more into the data that visual impairment doesn't just affect depression. There is actually association with all-cause mortality, and more significant with more severe visual loss. But a very interesting long-term study on over 2,500 patients from Salisbury, Maryland, from a cohort from the 1990s that followed up until about 10 years ago, showed that for every 1 letter drop of vision per year over 8 years, that was associated with a 16% all-cause increased mortality risk associated with various metrics of visual dysfunction. So that was actually news to me. It's not just the anxiety and depression, but there's robust studies showing it affects all-cause mortality. I'm in the age that I was a resident when we had verteporfin in trial, and that didn't improve vision, but slowed down for predominantly classic patients, CNVs, the rate of visual loss, but didn't recover vision for the average patient. We then had the first anti-VEGF therapy, which was Macugen. And because we were a little concerned, because the initial VEGF inhibitor monoclonal antibodies were given in high dose for advanced colorectal cancer, where we had, in those huge doses, some thromboembolic events, that there was a design to say what's the minimal amount of VEGF blockade we would need to get some sort of effect. And Macugen was a pegylated antibody that just blocked one isoform of VEGF-A called 165. And rather like verteporfin PDT, didn't, for the average patient, recover vision, but slowed down deterioration. The game changer was blocking all of VEGF-A, which was the ranibizumab trials and off-label Avastin. And the average patient then recovered some of the lost vision. Since that time, we've had Eylea, that's a VEGF trap that also blocks placental growth factor and VEGF-B, and Beovu, and then Vabysmo that also targets Ang2, and then in Eylea, high dose 8 milligrams. So these things are really great innovations. We discussed the data on the spectrum of use. The issue is in both clinical trials, and this is the CAT follow-up, that after the initial 2-year period, that most patients, the average patient, lost vision and dropped below baseline, with half of all eyes dropping below the UK legal driving standard at 5 years of 20/40. And we wanted to ask the question in the UK, since ranibizumab launch, where we really followed the Pronto approach, which was 3 plus PRN in 2007, 2008, to Eylea in about 2013, which was fixed dosing in the first year, to then treat and extend, are we doing any better? And in the UK, we have phenomenal data sets, and this is data on over 40,000 patients treated with anti-VEGF. And we looked at cohorts of 3-year intervals. Each of the colored lines on the chart on your right is a cohort of eyes starting at 2008 to 2009, and at 2-year intervals, but followed up for 3 years at a time. And the purple line at the top is the most recent, and the red line on the bottom is the 2008 cohort, but they all parallel each other. And it looks like we're doing better, but what we're doing is starting at better baseline visual acuities, and if you do a multivariable analysis, we are absolutely doing no better. All we're doing is starting at a little earlier vision. We are not getting any better, and the drop-off is the same. So our newer treatment regimes, fixed dosing, treat and extend, are not improving outcomes, and we're not getting any better visual acuity benefits from the newer drugs since 2007, 2008. So this data was surprising and a little disappointing to me. So although the VEGF-A therapies have been transformative to our patients with improved quality of life, and compared to Macugen and PDT, the average patient improves vision, but despite the multiple different options, we're not really getting improved visual benefits. We're getting suboptimal response in about a quarter of our patients. Most of our patients tail off after time, and many of our patients at each time point have persistent visual fluid. And we need frequent treatments, therefore, to preserve vision that's not really sustainable in many healthcare systems. So taking a little step back about the VEGF story. So we know that with inflammation and hypoxia, there's an upregulation of vascular endothelial growth factor because the eye kind of wants to try and repair itself. It's kind of a wound healing response. And VEGF attaches to a number of VEGF receptors that are on endothelial and other cells. And these VEGF receptors trigger an intracellular cascade through protein kinase intracellular pathways that affect angiogenesis, vascular permeability, which is often the main effect rather than regression of vessel growth, and inflammation. There are 3 types of VEGF receptors, 1, 2, and 3, and VEGF-A targets VEGF receptor 2 and 1. Placental growth factor that's blocked by VEGF trap aflibercept affects VEGF-1 as well. But we don't really have much that blocks VEGF-3, but we know that in various laboratory works that VEGF-C and D can block VEGF receptor 3 as well as blocking VEGF receptor 2. So our current anti-VEGF therapies slightly ignore VEGF receptor 3, probably don't completely block VEGF receptor A, and so there may be bypass channels that may be more efficiently targeted. We know that when you inhibit vascular endothelial growth factor, there may be a compensatory response with upregulation of VEGF-C and D when you inhibit VEGF-A. There's very homeostatic mechanisms in the eye as in the rest of the body. So there's a reasonable amount of evidence, as referenced at the bottom of the slide, that there is a compensatory upregulation of VEGF-C with VEGF-A inhibition either by trap or monoclonal antibodies. And diving into this story a little more, both in preclinical work, if we look at the images on your left, at the top left, we can see that in a vasculogenesis model where you have haploinsufficiency, so decreased VEGF-C, there is decreased vascular growth in this murine model. And in a corneal model on your bottom left, again, blocking VEGF-C reduces vascular permeability more, and this is backed out by the more commonly known laser-induced CNV model on your right, that if you block VEGF-C in addition to VEGF-A and placental growth factor, there's an increased reduction in the size of the CNV. So in animal models, there's clear signs of benefit from blocking VEGF-C and D in addition to VEGF-A. But are there any human correlates to this? So interestingly, there are studies that show that in patients with AMD, there is increased circulating levels of VEGF-C. And when you give anti-VEGF that blocks VEGF-A to our patients with neovascular AMD, there's increasing VEGF-C that increases over time. So there is human data that backs up these animal model data. So it seems attractive that maybe we should be blocking more than a VEGF-A alone. So in summary, our current therapies have evolved from targeting VEGF-A 165 that was very weakly but moderately effective to pan-VEGF blockade and VEGF blockade and placental growth factor, which have some benefits but have not been associated with improved visual acuity or really better outcomes visually. Neovascular AMD is a multifactorial disease, and as we've seen, when you target VEGF-A, there's upregulation of other VEGFs, and maybe we need to target other factors such as VEGF-C and D as well. So there's still an unmet need. We haven't got improved visual benefits over the last 15 years, and we need and would love better treatments. Thank you for your attention.